KL is a very good friend of ours. Again, he is a consultant in emergency medicine in the Rutunji Hospital on Hong Kong Island, a very busy place in the middle of the busy part of Hong Kong Island. But he also serves as the medical director of our fire service department ambulance command, and one of 3 medical directors in Hong Kong. And we're very happy he is going to give us a talk about paramedic training in Hong Kong, and then we'll have time for a few questions afterwards. Thank you, KL.
Well, good morning, everyone. I'm Dr. KL Mo. Thank you for the kind introduction. My lecture today will be on future direction of paramedic training in Hong Kong. So I declare no conflict of interest in my talk, and my talk will consist of 4 parts. The first one will be on current paramedic training. Second will be the agenda for future paramedic training. And third one will be on the new modalities of training. And lastly, I will talk about the train the trainer curriculum. So to give you some ideas of our paramedic training, this one is our training facility. It is called Fire and Ambulance Service Academy. You can see there are several buildings on this photo, and actually these buildings are specially designed for training purpose for our fire and ambulance service providers. So among all of the facilities in Academy, these are the most interesting ones. On the left side, you can see an MTR station. That is the Park Sing Kok MTR station. It is specially built for training purpose. You cannot find this from the official MTR map because no train will arrive at this station. On one side, you can see a jet plane, and this is not the Chek Lap Kok Airport. This one is our academy. So with all these facilities, we can conduct different scenario training for our paramedics. So let me give you some idea of our developments in the past. And the Fire Service Department first launched the ambulance service in 1990. At that time, only basic first aid will be provided to the public. And in 1993, we conducted our first paramedic training in Hong Kong. So we introduced the EMA2 course from British Institute of British Columbia, Canada. And by 2005, all our ambulances were manned by EMA2 qualified paramedics. That marks the major milestones of development. And in 2018, our paramedic training was taken place at the Fire and Ambulance Service Academy. And since the formation of the local paramedic development and accreditation advisory committee, and we began to localize our paramedic training course. And since last year, we run our first local paramedic training course in Academy. So this table gives you the idea of our paramedic training. So as you can see, we have 2 different levels of training. One is the foundation training, mainly for the recruits, ambulance men, and also officers. It lasts for 26 weeks. And the other level is the paramedic training. It is an 8-week training course, including the dialectics, simulation training, and also clinical attachment. And it was previously called the EMA2 training, but now it is localized and called the paramedic training program. And there is also an advanced skill level training. That is the integrated advanced skill provider training. It will last for 1 week. I will give you some more detail on the next slide. And our paramedics have to come back to undergo continuous medical education every 6 months, and they also need to come back for recertification every 3 years. For the IASP, Integrated Advanced Skill Provider, and a group of experienced paramedics will be selected. They will be trained up to perform 4 different advanced skills. They are the competitive insertion, video laryngoscopy for foreign body removal, intraosseous adrenaline injection for cardiac arrest situation, and also intramuscular injection, that is the chest pain for anaphylaxis. So I hope by now you can understand more about our current paramedic training. So let's move on to talk about the future. People always say future is now. The best way to define the agenda for training in future is actually look back and see what challenges we are facing now, so as to tailor our training to provide better patient care in future. And also, training is not an isolated component. It is closely linked to other entities, including the quality assurance, research, best evidence, and most importantly, the ambulance service and also patient care. So in order to predict the future, we should look into the service we are providing nowadays and project into the future. So the first agenda for future paramedic training is the new service model. So there are ongoing new service models developed for better patient care. As the first link in the healthcare service system, we work with other healthcare institutes to provide streamlined patient care. And all these new services involve training to our paramedics. So the pre-hospital ECG program for STEMI and pre-hospital stroke assessment with FAST are the best examples of training for new service model. And we train up our paramedics to perform 12-lead ECG to screen for STEMI. And also we train up them to have a stroke assessment and notify the receiving unit, so to prioritize the patient care and shorten the door-to-needle time for our patients. And all these involve additional training in order to make the program successful. Another development will be on the trauma patient care. We want to strengthen our spinal assessment of our paramedics. So currently we have no assessment tools for them to assess patients with spinal injury. And most of the time that will end up in a full spinal immobilization in the form of cervical collar, head immobilizer, and also spinal board. And according to the literature, this universal immobilization approach carries some drawbacks and risks. And this approach may delay the life-saving intervention of some life-threatening conditions like the airway obstruction. And for penetrating injury, actually spinal immobilization has no proven benefits. And also this can also give rise patients discomfort and also the potential complications. With more and more evidence, many overseas institutes actually publish policy statements and guidelines to advocate a more selective approach for spinal motion restriction. By the way, the term spinal immobilization has been changed to spinal motion restriction to reflect the reality that the spine cannot be totally immobilized. It can only be restricted in motion. So with all this, we come up with this new protocol for spinal motion restriction. It integrates the MOI and also patient condition for decision making. And the priority will be given to the life-saving procedure like the airway intervention. And for relatively stable patients, we make use of a modified nexus criteria to assess the patient and decide the best mode of spinal motion restriction for them. And for penetrating injury, spinal motion restriction is not indicated unless there is an associated neurological deficits. Another new service model is the end-of-life care. This is promoted by Hong Kong SAR government as part of elderly care. In the EOL care consultation report published by the Food and Health Bureau last year, the government is going to extend the DNA CPR order to pre-hospital care. A standardized DNA CPR form will be decided, And the fire surface audience will also be amended to enable this form to be accepted and enforced in the pre-hospital setting. So because of this direction, we conducted a survey on the altitude of our paramedics towards DNA CPR. And we recruited 400 paramedics last year, and they all give a very encouraging and positive altitude towards DNA CPR. Actually, they even asked for legislation of DNA CPR and also asked for formal training on DNA CPR related issues. So as a result, we propose to incorporate the end-of-life care in our paramedic training. And the training will cover the background of knowledge and the use of DNA CPR form, and also scenario training will be given to our paramedics to handle some difficult situation like the revocation of DNA CPR form. Another agenda for future paramedic training is advanced skill development. Since 2018, we have been training our ambulance officers to use ultrasound to detect intra-abdominal bleeding in trauma patients. And they need to undergo one-day training workshop that will cover all the theory and hands-on practice in performing fast scan. They also need to do the ultrasound scanning practice in the A&E department. There will be a supervised practice like what it is shown on this picture. The officer performing ultrasound on real patients. And they also need to pass examination before they qualify for the pre-hospital ultrasound application. And in the future, with the new handheld wireless ultrasound unit in service, our plan is to train up the officer to perform lung scan. And they can use the ultrasound to look for pneumothorax and hemothorax in trauma patients as part of the EFAST protocol. And also, we would like to include the ultrasound scan to look for cardiac activities in our hospital cardiac arrest patients. And the new ultrasound device can allow real-time supervision, and we can provide the real-time guidance to our officer to perform ultrasound in future. And also, we continue to look for the ultrasound compatible simulator. Like this one, we can perform the ultrasound and also practice needle decompression at the same time. Another development is about the special team. A special team called Outbreak Control and Response Team was formed last year. This is a group of specially trained paramedics who are responsible for infection control issues, training of the fellow paramedics, and handling high consequence infectious disease like the Ebola virus. They are equipped with the full PPE, positive air pressure respirator, and also the patient isolation port light shown up on this photo. They can transfer the patient safely from one facility to another. In order to safely transport the patient, Fire Service Department is introducing a special infection ambulance into their service. This ambulance is equipped with negative pressure system and auto disinfection function so that it can minimize the risk of cross contamination and spread of the virus to the general public and also the healthcare workers. And this ambulance has more space so that it can accommodate patients with ECMOs. And the OCR team members have to undergo a special training. They will be trained up and taught about their duties and equipment usage. They will also be trained up on the knowledge of infection control and high consequence infectious disease. They also have the opportunity to visit to isolation facility in hospital and voluntary control points, and they will be given drills and simulation training on handling the high consequence infectious disease and contingency scenarios. Hiking is an very popular sport in Hong Kong, and there is an increasing number of accidents related to hiking. And some people are even die because of the hiking-related injuries. So a special team of paramedics is recruited to provide better extended care to those victims who are trapped in the remote area and before evacuation. They will undergo 5-day training to strengthen their knowledge in trauma and wilderness emergency handling. And also they are allowed to execute extended version of protocols like the repeated dose of tramadol for pain relief in injured patients. They are also trained up to use the pre-hospital ultrasound to have better assessment of the patient's conditions. Another thing I want to talk about is the modality of training. Because of COVID-19, I think all of you attended some form of online training or online conference, just like this one. And this is an example of online lecture by the neurologist. The neurologist is delivering a talk on the pre-hospital stroke assessment using the Zoom platform. During the 5th wave of COVID outbreak in Hong Kong, our paramedic training was suspended. So in future, we hope to make use of this online platform to deliver our training and also the continuous medical education for paramedics in future and without further interruption of our training. Apart from the diabetics, scenario practice constitute a major part of our paramedic training. And as shown up on this photo, the paramedics are doing a scenario practice on handling a trauma victim inside a collapsed building. And on the right side, you can see this is a car accident involving a bus and give rising to multiple casualty incidents. And the paramedics are busy at handling a patient with bilateral lower limb amputation. So this is about the scenario practice. Another scenario practice is on board of ambulance. Because as you know, ambulance, when it is moving, cause a difficult situation for both the patient handling and also the occupation hazard to the paramedics. So they need to undergo some training to overcome the difficulties related to the vibrating condition inside the cabin. Just like on this video, the paramedics are handling an injured patient and they are trying to set up the IV access. And on the left side, the paramedics are busy handling a patient in convulsion on board of an ambulance. In the past, we focused a lot on the instruction teaching method and also the skill acquisition. And hopefully in future, we can focus more on the learners' reflection and also debriefing in our simulation training. And also we continue to explore for newer simulator like this one. This is a difficult airway management simulator so that our paramedics can perform video laryngoscopy to look for foreign object obstruction during the difficult airway situation. Lastly, I want to talk about the train the trainer curriculum. And after the localization of our paramedic training, we plan to localize the train the trainer course so that our paramedics can get more knowledge about the adult learning, teaching skill and tactics, and simulation training in future. They will also be taught about the evidence-based medicine and also medical legal aspect related to the paramedicine. And they will also be given an opportunity to have a clinical attachment to clinical units in hospital so that they can have more understanding of inpatient management. And of course, they have to perform scenario practice, and they will be given time to practice what they have learned from the dietetics, and also to conduct simulation training. And finally, they have to pass the assessment with external examiner. And I think in this way, the instructor standard can be upheld. And this is the end of my talk. And hopefully through this way of training, our paramedics will become more competent and proficient in deliver pre-hospital care to our patient, and our patient will benefit. And this is the end of my talk. Thank you very much for your attention.
Thank you very much, Kale. That was an excellent talk. Thoroughly enjoyed that, and very excited to see this new scheme, particularly for infectious diseases, given what we've been through in the last few months in Hong Kong with our terrible COVID outbreak. I'll keep the questions short just because time is against us today, but it strikes me that you are in the FSD way ahead of us in the medical schools in terms of simulation training. Do you see that as the future really for FSD, particularly with respect to skills maintenance?
Hello, Professor Grantham. Nice to meet you, and it's my pleasure to deliver my talk. Of course. I think simulation is a major part of our training. And actually, we use this modality of training even for our continuous medical education for the paramedics. So I think in future, as I mentioned in my lecture, we are planning to introduce more high fidelity way of simulation training. Of course, we need a bunch group of trainer so that we are training up our instructors.
Excellent. I mean, as I say, I think you're streets ahead of the medical schools in that respect. I think our nursing colleagues are way ahead of the medics as well. And we need to, especially in light of the experience of COVID, where access to patients has been difficult, we need to think of that as well.
Yeah.
I was very interested to see your comments on the interaction of pre-hospital and HA in terms of end-of-life care and DNA CPR orders. That data you presented, we've also seen from the CU side with our student who's been working with you on that. It strikes me that one of the conclusions of that is we need better integration between pre-hospital and hospital services in terms of the clinical pathways and the regulations. How do you see that moving forward?
Well, as I told you in my lecture, the government is going to change the fire service ordinance, because nowadays the fire service ordinance mandates all the patients should be taken to a hospital. We have to perform our duty as the ambulance service provider to continue resuscitation before we hand over a patient to the hospital colleagues. But in future, after the amendment of this fire service ordinance, we can enforce the DNA CPR in our pre-hospital setting. But of course, we have to integrate, all other stakeholders, especially from the hospital authority side, to join this program and make this successful and patient-centered, I would say.
Absolutely, and I think that would improve the quality of death as much as the quality of life for many of our patients who are at the end of life. Thank you very much indeed, KL. That was a super talk, and in the interest of time, I'll bring things to a close there. But thank you again for joining us today.
Okay.